Hello and welcome back to Discussing Creativity. I'm Marilyn Gugini and I'm delighted to welcome Dr. Malcolm Bryant of Concord to our studio today to talk to us about his work in public health. I'm going to tell you a little bit about him. He's an extensive background with over 30 years of experience as a clinician, educator, researcher, and manager of public health programs. He's devoted his career to the improvement of health outcomes by increasing access to high-quality health services. Dr. Bryant has designed and implemented reproductive and child health programs with continuing emphasis on the determinants of health and the development of community-based health systems. He's also conducted short-term consultancies in more than 15 African countries and Haiti, Latin America, and Asia. You have a few frequent flyer miles, I would assume. Yeah. In addition to the design and implementation of health programs, Dr. Bryant has evaluated numerous USAID field projects in Haiti, Nicaragua, Madagascar, Senegal, and the Philippines. Dr. Bryant is an associate professor at the Center for Global Health and Development at Boston University's School of Public Health, where he manages a research program seeking to improve quality and coverage of services to orphans and vulnerable children around the world through applied operations and evaluation research. That is quite a extensive resume, and you are clearly a world traveler. And it makes me wonder how one decides to get involved in a career in public health.
I sort of didn't decide to get involved in a career in public health. It chose me. I began my career as a physician in England, and I had always had this desire to go to Africa. It began when a high school teacher came back from voluntary services overseas, which is the UK equivalent, excuse me, the UK equivalent of Peace Corps. And he gave a lunchtime talk about his time in Uganda. And I looked at that and I thought, that looks like something I want to do. I was 14 at the time. And I spent the best part of the next 12 years working to get myself to Africa.
No kidding.
And along the way, and originally they were taking volunteers right out of high school. They changed the rules just as I got there, so you had to have your degree first. Well, I had decided by that time I was going to do medicine, so I finished my medical degree and they said, you have to have a specialty before you can go. So
it got harder and harder for you to try to get into this program.
Indeed. So, the choices were really do obstetrics or do pediatrics, because those are the main things that you do in Africa. So I chose obstetrics, and that was my specialty. So I was very lucky because people at the hospital knew that my plan was to go to Africa, and so the anesthesiology team helped teach me how to do solo anesthesia. The pediatric team helped me to understand pediatric resuscitation and the basics of neonatal pediatrics, which was really a good preparation for being pretty much solo in Africa. So we got there. My wife and I both went together, and I was running a district hospital in rural Zimbabwe, and doing all of the things one does. It was a particularly interesting time because it was right after independence. The Liberation War had resulted in a lot of destruction. The hospital had been closed but not badly damaged during the war. So myself and another South African doctor were able to get it back up and running. We got some basic equipment. We got things going. But sometime into my time there, I began to really understand that what I was doing was really just putting Band-Aids on people. And just as that was happening, Zimbabwe signed on to the Declaration of Alma-Ata, which was the declaration that came out of a very large meeting of public health leaders led by WHO in 1978. And primary health care was not something that was new, but it was really articulated clearly for the first time and signed on to by all the governments in the world as being the preferential way to do things. And of the 7 tenets of primary health care, curative treatment was only 1, and that was 6th out of the 7.
Oh.
So as I began to learn about primary health care as defined in the Declaration of Alma-Ata, and Zimbabwe decided that it needed public health specialists. It didn't have any, so it sort of said, you, and you're public health specialists.
Oh, so yes.
So that's how I became a public health person.
No
But I was
kidding.
very open to it at the time because I had really come to that conclusion that I was not wasting my time because I was affecting individual lives in the hospital. But I could see that by working in the community as a whole, I could actually do far more. And that's how I began in public health.
Well, thank you for giving me the background. I think that's a reassuring thing for a lot of people to hear. Is some people have a very clear sense early in their life of what they want to do, and sometimes it's becoming a doctor.
Right.
But some people don't always have a very clear sense at all. And so knowing that there may be just opportunities that come up along the way, if you're paying attention and you're saying, and keeping your eyes open, that might bring you to a place that you would like to be.
And that's what I tell my students too, who are all, they come to the School of Public Health incredibly anxious about, what am I going to do? I've got to have a career chosen. And I tell them, get at least 2 semesters behind you. And unless you know exactly what it is you want to do, get a couple of semesters behind you and understand the field, and then see what comes along.
All right, well then let's progress along as you went into public health. It's a very different thing than just being a clinician and a person who's actually serving an immediate need.
Right.
I assume there was a big change in the way of thinking for you and a need for perhaps a change in your approach to your own life.
Indeed. I think the biggest change for me was that I began to think about 2 of the things you mentioned in the introduction, is access to services and quality of services. And the thing that was so key for us in that part of Zimbabwe at the time was that there was virtually no access to services. We had the district hospital, which was a 4 to 8 hour journey by bus for many people. And if you weren't anywhere near a bus,
you walked.
It was really tough to get to. So, and there were virtually no health centers because of the devastation of the Civil War. So I spent a lot of time working with the government, local government, civil society, and with the private industry, mostly with tea plantations, coffee plantations, and forestry plantations, setting up a network of rural clinics that people could access, and also developing a community health worker program. And again, community health workers were not new, but they were very much, they weren't really understood how to go about developing community health worker programs. And so we made a lot of the same mistakes that other people made. We didn't go about choosing them terribly well. We didn't understand the local dynamics of communities as well as we should have done. So we had community health workers who went through their 6-week training, they got their free bicycles, and then they rode off into the sunset and were never seen again. And one of the things that we did learn was to use the existing local practitioners, so traditional healers and traditional midwives. And we did one of the first traditional midwife, traditional birth attendant training programs in Africa.
Well, we're going to take a jump forward and talk a little bit about your current work with really taking that experience that you had in the field and the many years that you've spent in the public health sector to the point where now you're evaluating other programs.
Right.
And saying, there's not enough data out there.
Right.
And people don't keep very good records. Isn't that what you're really finding?
Exactly what I do, yeah. And at the time, I didn't know what I was doing. I was self-taught. And it's interesting because close to the end of my time there, we had a visiting professor from the Harvard School of Public Health come through the district. He was part of a fact-finding mission for something else. We had an awful lot of people from the WHO, from UNICEF, and from other UN bodies come through. And this professor, we sat down over dinner one night, and he said, you know everything there is to know about practicing public health, but you don't know why you're doing it. And I think that you need an education. Why don't you come to my university?
Oh, great. Personal invitation. Okay. Sign me up.
Not quite as easy as that.
Okay.
But I did actually apply and got into the Harvard School of Public Health and did my Master's of Public Health there. And that's where I began to learn, I should have been collecting some of this stuff. I should have been paying more attention. I didn't understand the principles of epidemiology. I didn't understand the basic science of public health. I knew how to go about doing it. I had a good intuition. Did a lot of really good things. But I couldn't tell you definitively whether we made a significant difference in obstetrical outcomes, in child health outcomes, etc., in Zimbabwe during that period of time, because I didn't collect that data correctly.
But it's interesting that you're talking about that, because I think that's actually very equivalent to some other fields where people say, go get the experience and then come and get your graduate degree, because it will mean so much more to you. You will lock onto the concepts better. You will sink your teeth into it and be able to actually contribute things that people may not have already seen that have come before you. So, so now you're applying those professionalized concepts. And let's talk about your work with USAID and BU in specific. Tell us a little bit about what you're doing with orphans and vulnerable children.
Well, in the 25 years between that time and now, I joined Boston University just over a year ago. And what I am responsible for at the moment is I oversee and manage a large research program which is doing operations applied and evaluative research on the program that was created by the President's Emergency Program for AIDS Relief, PEPFAR.
Which started about 10 years ago.
It began in 2004. President Bush announced it in 2003. It didn't get funded until 2004, and the work really didn't begin seriously until 2005 to 2006. And most of the program, there was money specifically set aside for working with orphans and vulnerable children. That was identified as being underserved. There was evidence that this was a group that was suffering significantly from problems of poverty. How can I say? They were very badly neglected overall. There were a lot of programs that focused on child health, a lot of programs that focused on adult health, reproductive health, respiratory diseases, diarrheal diseases, but none that looked specifically at the problems faced by children who are orphaned or who have parents who are seriously affected by HIV itself and therefore can't live a normal life. So as part of PEPFAR, and I'll use the acronym, a percentage of the total amount of money, $15 billion, was set aside specifically to deal with OVC, Orphans and Vulnerable Children. That's the acronym that is used. And the problem was that it was regarded as an emergency. These children were in desperate need, we got to do something. But nobody really knew what to do. So money was put out there to provide services to the children educational services, psychosocial support, food and nutrition, healthcare services, a range of services, without actually knowing what worked and what didn't work. And because it was an emergency, it was treated much as you would treat disaster relief. It was, let's just get the money out there, let's just get children in care as quickly as we can, and let's worry about things later. The problem is that 5 years later, you've spent getting on for $1 billion, and you don't actually know whether you made a difference or not. Because being an emergency, you didn't take a baseline of how well the children were, what their conditions were, what their level of health was, etc. You didn't measure systematically along the way to see whether they're improving. So trying to do an evaluation at the end of a 5-year program when you don't know what the starting point is a bit of a challenge. And that's where we came in, was at the end of the PEPFAR program, trying to evaluate whether they were a success or not, and which is an enormous problem. So we have done our best to be able to do some of those evaluations, but like I was, when I was working in my district, the people had not kept good records to begin with. So, it's a big challenge. Now, PEPFAR was reauthorized a couple of years ago with a great deal more money, 10% set aside for OVC, which $50 billion put aside for $50 billion for PEPFAR. That's $5 billion for orphans and vulnerable children. So what the donor, the United States Agency for International Development, wanted from us was look at what's been done, see what's worked, and give us some recommendations for what we ought to be doing into the new program. So we've done our best with that. We've looked at a range of things, from community-based programming through faith-based organizations. We've done that throughout Southern Africa. We've looked in Namibia, in Zambia, South Africa, Mozambique, looking at a range of services that have been provided through churches, large churches, small churches, Catholic churches, Protestant churches.
Because a lot of the aid that's actually given is not by governmental organizations necessarily. Some of it is, and some of it's not.
It's a mix. The government provides services it's different in different countries. That's in some countries such as Zambia and Malawi, the government provides services where it can, but faith-based groups provide up to and sometimes more than 40% of all services. And it's mostly a function of how much money the government has. And one of the things that happened with the Bush administration was that they really emphasized working with faith-based groups and non-governmental organizations. So rather than a lot of the money going into the government, going into strengthening government services, it went into strengthening faith-based groups and civil society organizations. So what we were looking at was, in essence, how did these faith-based groups succeed? And what we found in that area was that the population of children who were served by these groups had roughly the same health indicators and outcomes as children who were not orphans and vulnerable children. So
that's good.
We make the assumption, and it's only an assumption because there's no baseline, that the interventions raised the level of health of these children to that of their counterparts. But it is only an assumption.
Right, because you didn't have the baseline.
Right. What we've been able to do now is we've been able to build in a longitudinal study. So we're able to study that same population and actually have now, with separate funding, collected a second round of data, which we did in March, and we'll collect a third round of data in the latter part of this year to be able to look at what's happening with those children in an ongoing way, to be able to look at other improvements, other problems. So, you know, we take our end of project evaluation that we did is actually our baseline for looking forward, because those children are still receiving services in
and you've actually now seen them and been able to establish a baseline.
Right. So really working in a scientific way to look at, you know, what are the outcomes for these children.
All right. So let me ask you, because we don't have too much time left, about creativity.
Creativity.
I mean, I can easily see lots of applications of creativity in terms of what you are doing as work, because you've had to explore so many areas that did not necessarily appear to you at first evident that you would need to. So you have to explore creativity just by going into whole new areas. But I would like you to be the person to tell me a little bit about, how does creativity enter your work, and is there any example that you can give me that you think, you know, in public health you apply creativity?
Okay. The area that I've really worked on, which I would say has been my most creative area, is trying to understand how a health system works in order to deliver that quality service to the person in need at a site that they can access. There's a lot of focus nowadays on something called health system strengthening. The World Health Organization, the United Nations, World Bank, the Global Fund to Fight AIDS, TB, and Malaria, they all use this terminology, but the definition of what that means is not at all clear. And one of the things I've done through the two previous organizations I've worked with, and, you know, coming into working with Boston University, is to try and model what does it actually mean to say we're delivering better quality services at the right place at the right time to the right people. And the thing that we've really boiled it down to is that at the point of service delivery, and that point could be in a clinic, it could be at a hospital, it could be underneath a tree in a village where, you know, a community worker is giving a vaccination. The healthcare worker needs to have 5 basic things. They need to have the skills to do the job. They need to have the equipment or the drugs or the supplies to be able to deliver the service. They need an infrastructure that is appropriate. You know, it could be a fully equipped operating theatre for a C-section, or it could be shade in the village to stop people getting, you know, sunburned and whatever. They need to have a referral system, so that, because nobody can deal with everything in one place, so they need to know where and when to be able to refer people, and they need to have information about the people they're working with. They don't need more than that. Those are, when it boils down to it, those are the 5 things that every care provider must have in order to be able to deliver a service. At the same time, this is not a one-way communication. It's a partnership. So the client of the service, and I say client rather than patient because they're often not sick, needs to have certain things as well. They need to have enough information to know whether they have a problem or not. Very often, people don't even know that they're sick or that things could be better. They need to know where they can get the service. They need to have an ability to access a service. They need to have the ability to understand the service when they access it. So it needs to be in a language that they understand, and it needs to be delivered in a way that they can accept it. It doesn't need to be rude, doesn't need to be done in such a way that they wait 8 hours in order to receive the service, so that they're so tired that they don't care about it. And they then need to be able to adhere to the service after they leave. So, if they're prescribed drugs, they need to be able to purchase the drugs, and then they need to keep taking the drugs. and if they aren't motivated to take them, if they can't afford them, if they're not available, they can't adhere. So if you look at that, there's, it boils down to there's basically 9 things that need to be present. 5 from the provider side, 4 from, I elaborated a little bit more on the client side.
But what I like about what you've just done is you've elaborated it very quickly and boiled down in a nutshell kind of the broad learning that you've had by looking in the field for all these years at various operations in various places with various basic needs, and come up with some very strong recommendations about what is needed. And I would assume that the next part of your process is going to be, well, then how do we make that happen?
Exactly. So what are the pieces that you need in order to make that happen from the service provider side and the community side? So there are in essence 2 systems that exist which have to come together. There's the healthcare system per se, and there's the community system that come together, and you can elaborate that in more or less ways.
I thank you, Malcolm, for having been with us today. I'm afraid we don't really have any more time to. This is a fascinating topic, and I'm sure that people will want to know where they can learn more about it. So let's just quickly, if you could, give a couple of websites, perhaps, that they can learn more about this.
All right. I currently am on the faculty at Boston University at the Center for Global Health and Development, and for that, the website is www.bu.edu/CGHD.
Okay.
And one of the things that I did a few years ago is, with a few colleagues, we created our own company to actually look at a lot of these quality and community-based issues. A group called IDEAS, which stands for Innovative Development, Expertise, Advisory and Development Services.
Okay.
And the site for that is www.ideas4 HLTH.com.
All right.
So ideasforhealth.com.
Wonderful. Well, thank you again for having been with us and talked a little bit about how you apply creativity in your everyday life as a public health physician. It's really interesting stuff, and since we're talking so much these days about, in discussing creativity, about helping the world be a better place, helping the poor, helping the disadvantaged, you fit right in to our theme. So thank you for having been with us. Thank you to the audience, and I hope that you'll join us again next week for another episode of Discussing Creativity.